Psychoanalysis technique, concept and issues. This is the second part of this series, concepts and issues. In the first part, we took a look at 10 concepts and issues in the domain of technique. And in this part, the second part, we will take a look at another 10 concepts and issues. And in this way, we will have 5 sessions of concepts and issues in the domain of technique. And these 5 sessions will cover 50 concepts and issues in the area of technique. So let us go into the second part of this series and cover concepts and issues from number 11 to 20. First concept, not concept, rather the first issue we will be dealing with is selection of the patient. It's a very important part of technique. Many therapists believe this is not even a question. What is there to select? We should take any patient who comes to us and asks for help. However, this requires far deeper reflection than a simplistic open door policy. How do you select a patient, or why should you select a patient at all? Should you not take anybody who wants you to help him? Isn't this a kind of a rejection of the patient? Isn't this a kind of abdication of the healing duty? All these questions come up in the selection of the patient. So let us look at how we select a patient. First, we should not select a patient that we cannot deal with. The patient may not know our strengths and weaknesses, but we do. Our supervisor does. So if you don't have capabilities in psychosis, don't take a patient of psychosis. Don't pretend to have expertise where you don't. So first criteria in selection of the patient is our own capability. Second criteria with regard to the selection of patient is whether financially and operationally the therapy is possible. If the patient is living too far away and cannot come to the clinic, he might say yes, you might say yes, in enthusiasm to start the therapy, but after a few sessions, he just gets tired out. Or if he is coming to you at a time which is not convenient to you, say 9 o'clock at night, you may do it out of enthusiasm for 3 months and thereafter the enthusiasm may go out. And so operationally it is not sustainable. Money wise, if patient cannot pay, again it is not sustainable in the long run. So second criteria is operational feasibility. Third criteria is money. Fourth criteria is the age and the gender of the patient. Are you comfortable in dealing with it? For example, I don't feel comfortable dealing with children, and so I never take children as patients. I don't have the skills which are required, which a primary school teacher would have, which a school counselor would have, or a therapist specializing in children, say ADHD or autism would have. I don't have those skills, so I don't take children as students, as patients. Similarly, I don't have skills in mental retardation. So even if an adult comes to me in mental retardation, I don't take it. So our capability, our experience is very important. Fourth criteria is, if the difficulty is severe, do you have the infrastructural structure to support demands which may come up at any time across the day. A severe case may call you up anytime in the 24-hour cycle, and if you are an individual who doesn't have organizational support, you may not be able to give good service. So infrastructural and organizational support is very essential in severe cases or in cases where emergencies can come up. Issues of language and education also are important. If you don't have the skill to be compatible in communication to those who are less educated or not comfortable in English, and you are educated in English, those elements also become very important, because otherwise it's very difficult to translate and customize something congruent to a patient where his vernacular language is something else. And lastly, is the person ready for the kind of time investment and energy that is required? A minimum psychological orientation, a belief in therapy, motivation of oneself, ability to deal with one's difficult parts, ability to be articulate about shameful parts of oneself. All these are very necessary in selection of the patient. So it cannot be an open door policy. We have to be very careful in selection of the patient. Second is the frame. Frame we talked about. Third is the case history. Case history we have dealt with in another session. It's a very important part. One of the tragedies of the mental health profession is that the senior professionals don't take case history themselves, they give it to their assistants. However, this is a point where time invested gives the best returns. If you take the case history yourself, you develop a grip on the unconscious of the patient, not a grip, but let me say a familiarity with the unconscious of the patient, far more than you reading case history taken by somebody else. And your pathogenesis and the treatment plan you evolve out of it are much better placed if you take case history yourself. It's one of the best investments you can make. The difficulty often is time, that the time of a senior professional costs very high, and some patients may not be able to afford it. Case history. Sorry, start of the session. It's a very important element of technique. How do you start the session and when do you start the session? When is very clear, you start it exactly on time. Even if the person comes a few minutes earlier, request him to be in the waiting room and only then come when the exact time starts. Similarly, you end the session at the exact time. If the patient comes late or by 10 minutes, even then you end it by the exact time. You don't push the ending time by 10 minutes just because the patient has come late by 10 minutes. If the patient comes late, he loses that time. And that is something he has to learn to bear and accept as a part of reality acceptance. That the world cannot be always customized to his needs. Now, how the session is to be started is very important. As a general rule, the therapist should not start the session, but allow the patient to start the session. At the most, you can say hi. Better if you don't say anything, but you can just smile, or at the most you can say hi. You can at best stretch it to say hi, how are you? But nothing beyond it. Because if you say how was the week or how was the day or how was the month, You are driving the session, you are giving a direction to it, you are starting the session. So we don't, substantially speaking, start the session. We allow the client and essentially the unconscious of the client to start the session. Another very important concept is the concept of silence. Silence is very important in the session. Often the client does not speak anything and the therapist also does not speak anything, but we are not referring to that silence. So there are three types of silences in therapy. One is when nobody is speaking and both are comfortable. This is for a short period of time, which is natural. The second silence is the silence of the room, which occasionally the patient focuses on and internalizes as the quiet space slowly inside of him. And third, and the most important, is the silence which most popularly we refer to as silence. The first two silences usually we don't refer to. But when we say silence in therapy, we refer to the third part of it, third aspect of, third meaning of that silence, or third type of the silence rather. And this third type of the silence is when the patient does not speak anything for a very long time, and at times, even despite the intervention of the therapist, the patient continues to be silent. How do you interpret this silence of the patients? What can be the causes behind it? There can be many causes. 15 interpretations of silence I have put here. First, patient may just be tired physically and therefore he just relaxes almost like a sleep when he falls down on the couch. This is more seen on the couch, less in face-to-face position. Second interpretation can be the person feels safe and relaxed in this room and therefore he is relaxing, which he does not feel outside, which is a good thing. Third, he wants to internalize the safe space and therefore he is focusing on the silence around, and a very important psychological operation of internalization of the safe space is happening. It is not that nothing is happening. It's a very important thing which is happening, but it's happening in silence. Fourth can be he feels good with the therapist and therefore he is relaxed and he can be silent. There is a popular line in Sherlock Holmes story where Sherlock Holmes and Dr. Watson, they go out on a walk. They walk for a long time without speaking anything to each other, and both of them are very happy and pleased. And Dr. Watson writes there, we walked for long without saying anything, as befits two people who know each other intimately. So this can be a silence of that type, that both of them are feeling good, and in that goodness and both feel they know each other. And this leads to a silence of comfort. The patient can be silent also because of anger. That because he is so angry, he does not want to talk because he fears if he talks, the whole anger will pour out. Or he just doesn't want to cooperate with you in therapy because he is angry at you. The anger can be because of repression, because something difficult is about to come up, and therefore the unconscious makes the person go silent. Silence can be because both of you have been talking past each other and he feels it's no point. You just don't allow him or just don't pay attention to him. And you are not understanding him at all. So the silence can also be because he feels he's not being understood. It can also be because he is disappointed with the therapist and he feels like giving up. He's done with everybody, including the therapist. The patient may be silent because he doesn't see benefits of therapy. Nothing is moving. So he's just passing time because he feels like he should just pass out a few more sessions before he says no. He may be silent because he wants to separate, but he is not capable of separating. He has a separation issue. He may go silent because you have had too many fights and the therapist has not displayed the capability of containment respecting the patient, and has entered into fights with patients which are completely unnecessary. The patient may go silent because he wants to dismiss all that you say, or he fears or he believes that you have dismissed all that he has said. The patient may go silent because of fear, right? That he wants to say something but he does not know how you will react. Or the patient may go silent because of DAM, which is destructive affect mobilization. That somehow you have made too deep an interpretation which has mobilized affect far beyond his bearing capability. And this happens often when theoretically we are very strong, we know the root of the problem, but instead of going in a mature, prudent way from leaf to the branch to the trunk to the tree to the trunk to the root, we directly go to the roots and make an interpretation. And this kind of a fundamental interpretation which directly attacks the root of the whole problem, whole tree of which is a proper tree of problem, in such case the amount of affect mobilized is far beyond the bearing capability, and this is what I call destructive affect mobilization, damn. And I always say, damned if you damn. So he may go silent because of this. There may be more interpretations of silence, more causes of it. 15 causes I have put up here. Self-revelation. The therapist has to be a blank screen, and preferably a white blank screen. And he should not do self-revelation, but despite best intentions, you can't bring self-revelation to zero. The way you look, the way you talk, the area or the building where your office is, the places in the city that you are seen, your charges per session, the way others treat you in the therapy space, all of it reveals something about you. Your writings or your books also reveal something about you. Your social media profile reveals something about you. The way you respond in communication with the patient reveals something about you. So, self-revelation can never be done to zero, but we should try to make it as less as possible. And more important than just confidentiality is the fact that information related to us important than just confidentiality is the point that information about the therapist should not become the point of discussion in therapy. So the information related to the therapy should not become a point of discussion. That is very important in self-revelation. Another important aspect of self-revelation is so the second aspect related to self-revelation is if the therapist is a blank screen, in the sense the patient does not have any real life information about the therapist, then all that the patient says about the therapist by and large is transference. And the more self-revelation we do, less pure the transference becomes. If there is 100% confidentiality and anonymity, we get 100% pure transference. Often it is also important that patients who have problem with emotional closeness, when the therapy takes depth and the therapist and the patient start getting close, patients often use real life information related to the therapist to avoid this closeness and stop therapy. All of this is taken care of if there is no self-revelation. If we are blank screen, we can have pure transference, as pure as possible. and we can point it out to the patient and use it very effectively for healing of the patient. Seventeenth issue is of approval. Many people feel approval is not necessary and it's not actually a part of psychoanalysis. We don't do approval validation kind of thing. So approval, validation, and corrective experience, these three things are a taboo in psychoanalysis. However, in reality, it's not true. In reality, we all seek approval and validation, and the patient also seeks approval and validation. And in most patients, when we give approval and validation, it works positively. In some, it may not, but in most, it does. So contrary to popular belief that we should never get into approval, validation, or a corrective experience, the fact is all the three happen in psychoanalysis, even if we don't want it to happen. And if we do it well, we manage it well, and we know for whom to do it and for whom not to do it and how much, we can make a very productive use of all the three. So approval is very important, especially when it comes to dependent personality disorders or high anxiety disorders, or patients who have been severely criticized or had very narcissistic or dominating parents. They do seek approval. It's only after some time they are able to give it. So to have a blanket ban on approval right from day one as a matter of principle is neither practical nor productive. 18th concept, validation. Validation is also sought by people, by patients, and at times we have to give it. We should give validation less than approval. Approval can be more liberal, validation would be much lesser, but occasionally it is necessary if nobody in the environment of the patient gives validation and there is a severe deficit of validation. In such situation, validation works very productively, and we have to be careful that it does not become an addiction, and we have to get into a tapering mode, whether it's approval, validation, or a corrective experience, which is generally by omission, not by commission. In all the three, we have to make sure that we are in a tapering mode. But we may have to do it, and we may not be able to practice the principle in its purest form. And I see nothing wrong in prudently using approval, validation, corrective experience, and tapering it off over a period of. 19th concept is containing. It's a Beyondian concept. What it says is that generally a large group of patients suffer from attachment problems of not only childhood but over a long period of time, and they never get attached to people who are peaceful and who can contain the stress that they bring, provide them support, absorb the stress, and give them back something happy, something positive, something peaceful, something secure. And this function of containing the anxiety, the stress, the negative emotions of the client into oneself, not getting disturbed by it, processing them into their positive equivalents or something harmless, and giving it back to the client. This is the process of containing. A good example can be a small baby, when it's angry, it hits the mother with its hands and screams at the mother. The mother takes in the aggression but does not return aggression in response. So even while the child is beating, the mother is smiling at the child. So the mother is taking in aggression and anxiety and processing it and giving back as a smile. So this is a very good example of containing, and this is a very important aspect of therapy. I think this is one of the most underrated and less appreciated concepts in psychoanalytic psychotherapy. Outside the Bjornian and the Kleinian circle, very few schools even recognize the importance of containing. And then you have different types of containing. So containing is a very important concept where you allow the client to park his difficult affects in you. You don't get disturbed by it. You process it successfully and give it back to the client in a positive way. So the input is a negative effect and the output is a positive effect. And in between is you as a system who is processing the negative effect into positive effect. And very importantly, one of the processing of this type is to take in the beta elements, convert them into alpha elements and give it back to the client. 20. The whole area of dream analysis. This again is like containing. It is not used as much as it should be used. I believe only the Jungians are using it to its full potential. Except for the Jungian school, most schools at some point used to have deep interest in dream analysis, after which it tapered off, and a very powerful tool is not being used to its full potential. There are some who do psychoanalytic psychotherapy only by dream analysis. That is another extreme. But to use dream analysis in therapy, one successful dream interpreted, even if it takes one full session, is like accelerating the therapy by 15 to 25 sessions. That is the power of dream analysis if you know how to do it well. The same dream can be interpreted differently by the Freudian school, the Kleinian school, the Jungian school. And if you know how to interpret the same dream using different schools, you can do it and then consolidate into one comprehensive analysis, and that is accelerating the therapy by 15 to 25 sessions. It's a very powerful tool of deep dive into the unconscious. I offer one course in dream analysis where we take up a dream and then using different schools of psychoanalysis, interpret the same dream differently and then put all the interpretations together to have a consolidated interpretation. So these are the 10 points, concepts and issues in the area of technique for this session. Next session, we will take up 10 more concepts and issues in the area of technique, point number 21 to 30. I hope this is useful to the audience. If there is something to be changed or improved, let me know. Write to me at hvindia@gmail.com. hvindia@gmail.com. Thank you.